Welcome everybody to GoLocal Live. I'm Josh Fenton, CEO and co-founder. Couple quick updates. First of all, if you haven't already heard, schools will not return to the classroom in Rhode Island. Governor Raimondo is going to formally make the announcement at 1 o'clock. This follows Governor Baker's decision in Massachusetts 2 days ago, in which he made the announcement. Also, the governor will be holding her briefing at 1 o'clock. And again, she still does not allow reporters to ask questions so that the public can hear them or take follow-ups. Let's go to Dr. Michael Fine. Dr. Fine, how are you today?
I'm good. Good afternoon. We got nice sunshine.
We have nice sunshine. I'm always a bit loving the sunshine personally and worrying about how many people will go out without masks and not stand 6 feet apart from each other. But we'll talk about that another time. Let's go to the numbers. Across the country, Massachusetts crossed over 2,000 deaths related to the coronavirus. What are the other key numbers people need to know?
731,000 people have recovered around the world. 2.69, almost 2.7 million people tested positive around the world. In the U.S., 857,000 people. We're likely to cross 900,000 in the next 48 hours. 186,000 deaths around the world, still growing, unfortunately, at 6,000 deaths a day. In the United States, 47,000, almost 48,000 deaths, still growing, about 2,500 deaths a day. And given the rate of continued positive tests, I think we've got to look at that number of deaths for the foreseeable future. For the next 4, 6, 8 weeks, I'm going to guess. In Rhode Island, we have 5,800 cases. We'll cross 6,000 today. I'm pretty sure 10 deaths in the last, up till yesterday, 181 deaths altogether. But miraculously, our hospital utilization and IC utilization is holding firm. There are some people looking at some projections who think that we are at the surge now. But when I look back at the number of new cases over the last 10 days, I don't think we're there yet. I think we're going to see another 20 to 30% increase in hospital use, and I don't look for it to really peak for another week or two, because what we see in hospitals reflects what was happening in the community 3 weeks before. And then when it peaks out, again, I think it's going to be more a high plateau. We're going to see a number of weeks of, sort of more of hospitalizations, and a number of weeks of, daily deaths that are higher than we want, but not astonishingly high, and then a gradual, eventual decrease. But I don't see that gradual, eventual decrease for 3 to 4 weeks out, and I'm happy to be wrong about that. I'd be thrilled to have that happen sooner.
So a number of things that are developing. There's a big discussion, seems like in the northeastern states and a little bit at the national level, about contact tracing. We've talked about it before, but New York's now pressing forward with it. Governor Baker's talked about pressing forward with it. Let me run a scenario by you. If on April 13th, 10 days ago, only 5,000 people had contracted the virus, some obviously being symptomatic, some being asymptomatic. And each of them over 10 days only came in contact with 5 people. And those people only came in contact with 5 people. Maybe the most conservative estimation of a scenario that you could possibly construct. That's 125,000 people. Is it good use of resources for the Department of Health to try and track 5,000 people times 5 people times 5 people? Functionally, shouldn't we just assume that most of Rhode Island has been in an environment in which they could have been exposed, and then let's move on to testing in order to be able to open up the economy, return to whatever the new reality is?
There's nobody better at contact tracing than the Department of Health. But I think the numbers are really troubling in terms of what people can do. I mean, think about it. We're adding 350 to 400 new positives every day. And how there are going to be enough people in the universe to keep up with that is a little unclear to me. My sense is testing plus isolation. You've heard me talk about isolation, and I guess I'm obsessed. But you know, for me, isolation, as soon as there's a symptom, testing to find, and I was wrong about this yesterday as I did a little more reading. There are people who are asymptomatic who test positive. The rate of false negatives is higher, but it does help us get to some people. But finding those people, getting them into isolation, getting people with symptoms into isolation, until our numbers really markedly drop. And then when they markedly drop, then contact tracing becomes incredibly useful. But I think our energy ought to be put on isolation first, testing second, making sure that anyone who's an asymptomatic carrier gets into isolation until they've cleared. I think that's the way out of this at the end of the day.
The other new, favorite toy is some businesses are buying heat sensors to measure individuals' temperatures. That doesn't really make a lot of sense either in my book, in that the research is showing that you're maybe most contagious 1 to 2 days before you generate any symptoms at all, including that fever. So those that are most contagious would not be detected in these sensors, and thus would go in, cleared at that business, walk in and contaminate most everyone.
Well, I'm a big fan of temperature checking, to be honest. And I think what we're really doing here is kind of cribbing points. You know, we're going to get just because people are most contagious 2 or 3 days before doesn't mean that they're not contagious when they're symptomatic. Certainly, when they're symptomatic is when they're most likely to test positive, and probably pretty darn contagious. So the trick, depending on how long into their diseases, when they're 5 or 6 days after the first symptom, their level of contagion probably rapidly falls off. But in the first couple days, you better believe it, they're contagious. And, if we can find a couple extra people by doing temperature sensing, more power to us. If we can find people by widespread testing of asymptomatic people, particularly asymptomatic people who've had a recent exposure, because a lot of the technology of testing has to do with what the pretest probability of disease is. So it seems to me that people who have a real contact have a higher pretest probability. We should be testing them asymptomatically. We should be testing all healthcare workers and all frontline workers, recurrently and repeatedly as soon as we have enough testing. And as soon as we've spread that testing out into communities, part of our testing hassle has to do with where testing is and that it's a hassle to get. And actually, part of it has to do with the need for a physician's order. There are likely 300,000 Rhode Islanders who don't have a primary care clinician. And we don't really have a good pathway for that group of people to get tested. I think we need to sort of grow up and understand that for this condition, not for everything, but for this condition, this is this is one of those things that we ought to allow people to self-order their tests, as it were. We do that for pregnancy tests, we do that for diabetes screening. What the heck? We need this testing now.
I want to go to the condition of the primary care business model in a moment, but I just want to go back to a little bit of the method of the madness that I'm outlining. Ultimately, something like thermal testing, whether it's through some type of body sensor or otherwise. If it's missing 20%, 10%, it's not very effective. It's a little like going through a metal detector that only measures from your waist up. Shouldn't all the resources, listen, we know we can't return to work. We know we can't open schools until we start testing for the antibodies. So why these, I'm going to call them in a derogatory term, fool's errands of contact tracing and of thermal testing, when we know that neither one is going to be particularly efficient? Why not build the infrastructure right now while we're doing the primary testing to see who is actually testing positive, and build that infrastructure right now so we're not further delayed months? We have limited resources. The governor's talked about it. Taking our best and smartest people off of contact tracing and having them build an infrastructure for the antibody might be a better use of resources.
Well, I'm with you about infrastructure building. I actually think temperature screening might help us find people who we don't already know about, and it deals with people's denial and the notion that we have made a compromise and had people keep working. If people weren't working, I might not think it's a big deal, but it's relatively easy to get somebody standing in the front door, and they don't have to be a rocket scientist or have huge training. With a little temperature, they have these kind of cool little temperature guns. I don't know what else to call them, that measure your temperature without touching you. To me, that's a relatively low cost, low hassle. Let's just do it and see what we can pick up. But I think you're really right about infrastructure. And, it's something we don't see in Rhode Island. For as long as anybody can remember, we've only had a State Department of Health. And that's been a great thing. But I think we may now need an infrastructure that's local health departments, local health presence that organizes testing locally, community by community, that organizes isolation locally, community by community, that goes back and checks on people. And actually, we could put a whole bunch of people back to work engaged in this kind of public health work in a new way. And we need it not only for this, we're going to need it come fall for influenza vaccination, because this is the fall to take us from 37% vaccinated, which is our traditional number, to 90% vaccinated, which will protect us during the winter. This is the fall to really get serious about helping everybody quit smoking and pushing people to quit smoking community by community and neighborhood by neighborhood. And we need a local infrastructure to do all that and more.
Let's jump over the primary care physicians. They are absolutely the backbone of the healthcare system in Rhode Island and in every state. As you said, listen, 30%, 300,000 Rhode Islanders don't have a primary care physician. They're also the ones that keep costs down, because as you visit your primary care physician, you're doing preventative medicine on a regular basis rather than going into that emergency room as sort of the last opportunity. Many of them are under tremendous financial stress. Talk a little bit about what the economic condition is of those who are solo practitioners or small group practitioners, and what economic position they're in right now.
Oh, they're struggling. I mean, they've done an amazing job making the transition, like in a second, to telephonic care. But lots of people became afraid of going to the doctor because of, afraid of being infected in waiting rooms. And so their actual business vanished. We have been doing, this is the moment to look at the things that we've been doing for the last 20 years that are dumb. For the last 20 years, we have continued to pay primary care physicians, clinicians, and practices when a patient walks in the door, when we know really well that we should be paying them per person per month for everybody on their list, a process called capitation. And doing it well enough, man, if there was ever a moment to make the transition, that transition is now. Because if all those folks had, X number of dollars per person per month rolling in the door, they would be able to transition to telephonic care, be able to reach out and check up on people and not have to worry, not have to count how many people walk through the door or in the current environment, how many telephone calls they're making, and bill for each blinking telephone call. I can't believe that we make people do that. That's so debasing and so absurd. The billing process for primary care costs primary care clinicians 20 to 40% of what they make. That's just dumb because it adds no value. So we ought to make the transition, grow up, get over it, and make the transition to capitation tomorrow. And then all those primary care docs would be able to support themselves, and they'll be ready to help us when we have to get everybody immunized, and be able to help us when we have to go through what looks like most people think of as going to be a second peak in the fall or the winter.
I think you undervalue the value of billing in medical offices. Where would those cranky billing people go and work if those jobs did not exist? We would have to get many more meter mollies or things like that to be able to fill those positions.
We need them. We need them to go out and check temperature, help people get into isolation, and support people in isolation. They're wonderful people as a group, but
they never seem very cheery when you call them. But we'll save that discussion for once we get through the pandemic. Let's talk a little bit about. The governor made an utterance yesterday. I cannot believe she's not going to walk it back. That people who are 60 years or older need to be restricted from re-entering the workplace and a number of other conditions. She often talks about making decisions based on numbers. That number doesn't seem to be the deciding metrics for demographics. It does seem to be, certainly you could make a case maybe for 70, certainly for 80. No two ways about it. But that 60 number doesn't really hold up on any of the measures, either locally or nationally. What was she trying to get at? What was I assume that came from advice from the Department of Health.
Well, I've seen some data from the Department of Health that suggests they believe, and I haven't rerun these numbers myself, that the risk of death for anybody over 60 who gets coronavirus is 10 times people who are younger. And I think that's what's likely driving this. That is what it is. I think there's still room for personal decision in making choices like that and understanding personal risk. The real challenge, I think, is not keeping people who are 60 out of the working place, but getting workplaces to be really top-notch about making sure they're screening all their employees. Do we want to eliminate 60-year-olds, or do we want to make it so that there's regular testing of all employees when there are groups of employees, and regular temperature checking, forgive me, and just staying so much on top of it that we don't get workplace transmission. My guess is we're having bunches of workplace transmission.
Yeah.
And that's the result of keeping workplaces.
Doctor, can you hear me?
Yeah.
Oh, okay. You cut off a little bit there. Let me raise a last issue. And before I go there, on workplaces, as you may have seen, one food processing plant down at Quonset had over 100 cases. And surprisingly, what I was surprised at is that they've decided to keep that facility open moving forward. 100, I think there's around 500 people who work in that facility, at least it was historically. That seems like an unusual decision to keep the facility open.
Yeah, and I don't want to second guess anybody, but if you look around the world, countries that have been most effective, take any congregate setting where there's been a case, and they basically close it down for a couple of weeks, get everybody tested, give everybody a chance to recover before opening. To me, that's we're going to need to do that with workplaces, we're going to need to do it with government buildings, and we're going to need to do it with schools. There are going to be outbreaks in these organizations, And if we're going to be successful at this across the state, we've got to be aggressive about the folks who, about the congregates, any congregate setting where there are outbreaks. And that's painful economically, but it's more painful to stay closed because we haven't done that.
JAMA published a very significant paper coming out of New York City, one of the largest hospital groups there. And it had a number of findings in that paper. One was a number of pre-existing conditions and what their impact was on recovery from the virus, but also that 88% of all patients who went on to ventilators died. There's been some debate emerging over the past few weeks about use of oxygen versus ventilators. And interesting, Boris Johnson refused to go on a ventilator, and they treated him with oxygen when he was in the ICU. Your thoughts on the data that's emerging and what healthcare professionals need to know, and also families need to know if one of their family members are going in for an emergency situation with the coronavirus, and what they should be making, how they should be advising decisions.
Well, we're learning every day, and I'm not doing the intensive care unit stuff, so I don't have a moment-to-moment feel. From what I'm reading, there's tremendous amount of work being done on patient positioning. So putting people in the prone position seems to be helpful. I think a number of ICU and critical care doctors were troubled that they would find somebody who was alert and talking to them and didn't seem short of breath, who had an oxygen level as measured that was low enough to require intubation. And so I think they've backed off from that. There's some stories floating around about a hypercoagulable state where blood is clotting inside the arteries and veins, and how that may be contributing to the pathophysiology of this. It sort of I can make an argument for that contributing quite importantly. And so we're learning things about anticoagulation, or at least experimenting with anticoagulation for the treatment of disease. I don't want anybody to be in the position of second guessing a clinician. The folks who are there with the patient ought to make the decisions and make them in a way that's similar to what Boris Johnson had, which is what we call shared decision making, so that the physicians lay out the risks and benefits of a choice and then involve the patient in that choice. So I can't guide families. I mean, families are in a painful place because they're not there. They're there only by phone, and that's very different.
Is the science moving fast enough? Listen, almost week by week, there is new information, new studies, new data that almost, I don't want to say conflict, but certainly don't completely align with what the best practice was the previous week. Is the information significant enough that JAMA paper seemed to have substantial sampling size, and it was from a substantial healthcare organization? But is that information getting out as quickly as it needs to Westerly Hospital or Biloxi, Mississippi General, or wherever it needs to go?
Well, obviously, I can't speak for people in their locations and institutions, but the real robustness of healthcare and medicine is the way people exchange ideas and work really hard to stay up, to figure things out, to communicate with each other, to learn from each other. I used to say that the lifespan Care New England, sort of antagonism used to drive me crazy, because that antagonism was happening in the C-suite, but it wasn't happening among clinicians who learn from each other, collaborate, are about taking care of human beings. And I think that continues pretty much everywhere. Can I promise that it gets to every hospital and location in the state? Of course I can't. But that's what departments of health help with. That's what physician organizations help with. I get stuff every day, and I suspect many of my colleagues are actively involved with reading it. The Department of Health does an every week large conference call For clinicians, they get 800 people on a conference call, putting out the most current information. So we're all working hard to do it, but science takes a little time. On the other hand, people are just doing this all the time and thinking about it every minute of the day. So I think there's as much attention brought to it as one could imagine, and that's entirely appropriate and something that I think we all ought to be thankful for.
Dr. Fine, you have the last word. Tell us what we need to know, what people should be doing.
Go out in the sun, put a mask on, go for a 45-minute walk by yourself, or with somebody 6 feet away or 8 feet away, or somebody you live with regularly. I mean, get out and get some exercise. Talk to your friends and family. Make sure you stay connected, so you are emotionally strong to get through the next number of weeks, and plan on it being a number so you're not disappointed when it is. And if it's shorter than that, then we have a moment to celebrate together earlier.
Dr. Michael Fine, thank you very much. As always, for everybody else, 1 o'clock, Governor Raimondo, her briefing. Thanks everybody for tuning in. Stay tuned for some new updates coming from GoLocal on a number of developing issues. Those will be published shortly, and there will be an e-blast coming out in the next little bit. Thanks everybody. Appreciate you taking the time. Please, please stay safe.
Thanks, Josh.